will the introduction of ARNI reduce the need of device therapy in heart failure with reduced ejection fraction? So that is the question. Will ARNI change or can it prevent the ICD or CRT? See, so far the guidelines are very clear and consensus is very clear for secondary prevention, like any heart failure with reduced ejection fraction, EF less than 35% and recovered from ventricular arrhythmia, they should be on ICD class 1A indication. If patient for primary prevention, that is ICD still indicated if EF is less than 35%, in spite of guideline directed therapy for more than 3 months, symptomatic class 2 and 3, they should be on ICD even if they had never had a arrhythmia in the past. But if it is a ischemic heart disease or a myocardial infarction or revascularized patients and still their EF is low, maybe we need not wait for 3 months. After 40 days, if EF is less, we can put a ICD. So these are the guidelines. For IHD patients, we need not wait for 3 months. If prior MI, that is scar, is there, beyond 40 days, if their EF is less than 35%, likely survival is more than 1 year, they are candidate for ICD. CRT is different ball game. If heart failure with reduced ejection fraction and LBBB or QRS duration more than 150, they can be put on CRT. If non-LBBB and still wide QRS, they can be, but there are better echo criteria and other criteria to select who should go for CRT. Now the issue is, these devices were never studied with the ARNI, but after paradigm and after so many trials, there were good data which came out that ARNI remodels the ventricle in a very favorable manner so that their new incidence atrial fibrillations were reduced, the burden of atrial fibrillations were reduced, in fact arrhythmic deaths were also reduced. So the question came up, whether can ARNI prevent ICD or CRT? So that is why the cautious guideline came up that you put them on 3 months of ARNI, that is guideline directed therapy, beta blockers, ARNI, MRAs, SGLT2, and still after 3 months if there is no improvement or suboptimal, we can consider them for ICD. But we have seen in practice that after the introduction of ARNI, many of the patients, they improve their EF. In fact, they maintain that EF for a long period of time. What needs to be done for them is not known, but guidelines are clear. We must continue them on ARNI. So that is why there is a subclass by European guidelines that heart failure with improved ejection fraction. So why they have been? Because everything starts, can we stop the medicines? Can we now stop ARNI and put them on this? So the guideline says, please continue the ARNI. Those improvements were on these drugs. If we stop them, they are likely to fall back again.